Hello everybody, this is Dr. Podell. I'm an assistant professor of medicine in Medical College of Wisconsin. Today we'll be talking about acid base, which is a part 2 of our lecture series. The audience for this lecture is a fourth year medical student. Let's dive into it. So let's talk about steps to interpret ABG. You start with identification of primary disorder, whether it's acidosis or alkalosis. How do you do that? You look at the ABG pH. So we already talked about normal pH range 7.38 to 7.42. But for practical purpose, anybody with pH more than 7.40 has alkalosis. Anybody with pH less than 7.40 has acidosis. So once you know primary disorder, then you identify primary process. How do you do that? So let's say your patient has acidosis and has high carbon dioxide. Most likely it's from the respiratory acidosis. On the other hand, acidosis with low carbon dioxide most likely from metabolic origin. Then you calculate anion gap. How do you calculate anion gap? You first add bicarbonate with chloride and you subtract that number from sodium. Normal anion gap is 12. So sometimes your patient has low albumin number, then you need to make a correction. How do you correct? So let's say your patient has albumin of 2 and then you calculate anion gap 15. So the corrected anion gap in this case is going to be 21. So 1 gram drop of albumin from 4, which is a normal albumin number, 1 gram drop from 4, you add 3 to anion gap. So this patient we just talked about has 2 gram drop from 4. So for 1 gram drop you do 3, you add 3, the second one another 3, so you add 6 to 15, which is 21. So that is a corrected anion gap. Then once you calculate that anion gap, you calculate delta. So delta means how much more anion gap patient has. So that anion gap minus 12 is going to be delta. Why delta is important? Delta has negatively charged. So since delta is negatively charged, it is going to occupy the same compartment occupied by bicarbonate. So with that degree of acidosis, with that degree of delta in the system, the expected bicarbonate is going to be low. So how low? Normal and bicarbonate is 24. 24 minus delta is going to give you the expected bicarbonate for that degree of acidosis. So let's say you calculate expected bicarbonate, and that calculated expected bicarbonate you compare with the BMP bicarbonate, and if that bicarbonate that expected one is more and the patient has less. So let's say the BMP bicarbonate is more than expected bicarbonate, then patient has metabolic alkalosis. If patient BMP bicarbonate is lower than what you expect, then less bicarbonate is metabolic acidosis. So that's how you calculate metabolic disorders, whether patient has metabolic acidosis or metabolic alkalosis. Once you are done with the metabolic calculation, you calculate respiratory compensation. We calculate expected carbon dioxide by Winter's formula. Winter's formula is bicarbonate into 1.5 plus 8 plus minus 2. So that expected expected carbon dioxide number you compare with ABG carbon dioxide. So let's say ABG carbon dioxide is more than expected carbon dioxide. That means patient has respiratory acidosis. On the other hand, if the ABG carbon dioxide is less than expected carbon dioxide, that means patient has respiratory alkalosis. Once you do this metabolic calculation and respiratory calculation, you know what disorder patient has. Then you try to paint the picture by going over the mnemonics of anion gap acidosis, which is gold mark, and then non-anion gap acidosis, which is hard ups. So you go over each and every of those different cells and try to paint the empty canvas with the information that you have. So let's talk about primary process, respiratory or metabolic. So as you all know, PCO2 normal number is 40, bicarbonate 24. So let's say somebody has acidemia and carbon dioxide is more than 40. Then you know the primary process is respiratory. And let's say if you have acidemia and PCO2 less than 40, the primary process is metabolic. Similarly, if somebody has alkalemia, PCO2 more than 40, it is metabolic. And if somebody has alkalemia and PCO2, less than 40, that means it is respiratory. They are washing off their carbon dioxide. So remember, respiratory compensation is immediate. On the other hand, renal or metabolic compensation takes time. It lags behind by almost 6 to 12 hours for onset, and it requires almost 1 to 2 days for reaching steady state. So somebody with metabolic alkalosis, it's compensated with hyperventilation, but it cannot result in PCO2 of 55 or beyond without causing respiratory arrest. Similarly, if somebody has a metabolic acidosis, you compensate with hyperventilation, but that hyperventilation is not good enough to bring that PCO2 below 12. So remember that. So, and then primary process are never completely compensated. They're only partially compensated. Since they're only partially compensated, you have always some clue to the diagnosis of primary process when you look at the pH. And then compensation can not do total correction. Remember that. Except in the case of chronic respiratory alkalosis, that's the only primary disorder where compensation can actually result in the normal pH. Remember, general rule of thumb, you cannot overcompensate. Let's talk about compensation. So I have put all the formula that you are supposed to know for acid-base calculation in this one slide. So make sure you use this slide for your future reference or any calculation that you are going to do in the future. And all the example acid-base cases that I'm going to give it to you, make sure you are going to apply all this compensation formula. All right. So we already talked about metabolic acidosis expected by PCO2. So let's talk a little bit about respiratory compensation. So in respiratory acidosis, whenever carbon dioxide goes up, let's say by 10, pH is supposed to go down by, you multiply this 0.08 with 10, right? So that is going to be 0.08. So if somebody has a PCO2 of 50, which is 10 above the normal, the pH is supposed to go down by 0.08 if it is acute. If it is chronic, let's say COPD years, if they have a PCO2 of 50, it is supposed to go down by 0.03. You have to multiply 10 because this is per 1. So that means pH is supposed to go down up to 7.37. All right, so there are 4 different kinds of respiratory failure. Type 1 is called hypoxemic respiratory failure, where the oxygen number is down. Type 2 is not only oxygen down, they also have high carbon dioxide. So remember, carbon dioxide is very much permeable. So if somebody has problem with carbon dioxide retention, most likely the disease is not in the respiratory membrane. It's somewhere higher up. Then third type, type 3 is a subset of type 1 failure, but it tends to occur in the perioperative setting. And then type 4 is with somebody who has a shock. Um, in respiratory failure, type 2 respiratory failure, where you see respiratory acidosis, if you treat the underlying cause, you are going to fix that respiratory acidosis as soon as you put that patient on mechanical ventilation. The correction is very much easier, which is in contrast to type 1 respiratory failure, which is rather a little bit difficult to treat, because in type 1 respiratory failure they are hypoxic, and then when they are hypoxic there are 5 causes of hypoxemia that I'm going to talk about. So you need to look into those hypoxic causes, and you need to actually correct those causes of hypoxemia before your patient gets better. On the other hand, problem with type 2 is ventilatory deficit, which is immediately corrected as soon as you put them on ventilation. So let's talk about type 1 respiratory failure and indications of oxygen. So at rest, when you do pulse ox and then pulse ox number is 88 or less, or if you do ABG and the ABG number is 55 or less, people qualify for oxygen. So those are the indication for oxygen. So sometimes people are chronically hypoxic and they have a feature of chronic hypoxemia. So remember, low oxygen concentration in the pulmonary circulation causes pulmonary hypertension, which is completely in contrast to systemic circulation where low oxygen or high carbon dioxide results in vasodilation. So in the pulmonary circulation it causes pulmonary hypertension, and if somebody has pulmonary hypertension for some time, they tend to get feature like pedal edema or dependent edema, and they also have P pulmonale in the EKG, which is a tall P wave. And also some people, they tend to get polycythemia when you check CBC. Polycythemia, which is defined as hematocrit greater than 56%. So when you have these three feature of chronic hypoxemia, people qualify for oxygen even with the high number of pulse ox. The number we are talking here is 89. Or if you are doing ABG, anybody with PO2 less than 60. So the number we are talking here is 56, 57, 58, and 59. So if somebody has feature of chronic hypoxemia, they qualify for oxygen even with the higher numbers, which is 56 to 59. So first three component, ventilatory pump, and then fourth and fifth, basically type 1 respiratory failure. And remember the last component, that is cardiovascular system and hemoglobin, that constitutes the gas transport system to the tissues. In the case of shock or in case of severe anemia, type 4 respiratory failure occurs, that actually, contributed by this component, this last component. So these are the 5 causes of hypoxemia. Start with the VQ mismatch. So the way I remember this is let's just start with with the condition that results in normal EA gradient. So let's talk about that. So let's say if you are in the abrest, high altitude, if you go here, if you are in the abrest, or let's say if you're in the average, or if you have taken something, some drug, and you feel like you are in the average, those are the two conditions where your A gradient is going to be normal. Then there are conditions where there is diffusion limitation. So diffusion limitation means there is something wrong in the respiratory membrane or VQ mismatch. Either there is a disease on the alveolar side or there is a disease in the blood vessel side that is resulting in VQ mismatch, or they have intracardiac shunt, connection between right and left side of the heart. So these are the three conditions where a gradient are increased, and those two conditions where people either they are in the arrest with a low oxygen tension, or they have taken something that makes them feel like they are in the arrest. They have taken sedatives. So those are the two conditions where a gradient is normal. All right, let's talk about a gradient. So in a gradient, what you are supposed to do, you are supposed to calculate the big A, because big A, you already know the small a from ABG. So big A, how do you calculate big A? Big A is calculated by this formula over here. So if you look here, so this formula over here, so and then out of this formula, remember this part is constant, this part is always 150. So you calculate this as 150, you put 150 over here. And then this part, the second part, this PCO2 is from the carbon dioxide of ABG. And you divide that by 0.8. So this is the Milwaukee specific, PaO2. So let's do some math. So somebody who has a ABG of this 65 carbon dioxide. So let's calculate a gradient. So first you start with the big A. So 150 minus 65, which is carbon dioxide number, divided by 0.8. So this is going to be 81.25. So when you subtract, it's going to be 68. So this is 68, and is that a normal A gradient? So you calculate that. So what is the so that is A, big A, and then what is the small a? Small a, you know, from here is 55. So 68 minus 55 is going to be 13. So that is your A gradient. So you calculate the normal A gradient. Normal A gradient is divided by 4. So our patient is of 48. So that is 12, and then plus 4, that is 16. So our patient ABZ revealed normal A gradient. So a gradient, out of those 5 causes of hypoxemia, a gradient is normal when somebody is in high altitude or somebody is hyperventilating. So those are the two conditions where A gradient is normal. In all other causes, A gradient is elevated, and actually helps you to, figure out the cause in those folks. All right, let's talk a little bit about respiratory alkalosis. So hyperventilation reduces arterial PCO2 and consequently increases the arterial pH. The most common causes of respiratory alkalosis are early shock. When somebody has a shock, they actually breathe faster because they have a metabolic acidosis because of the lactic acid, and they are trying to clear that by breathing faster. In fact, this is the earliest acid-base disorder of hypovolemic shock. Some people with CNS lesion, either from infection or from CVA, they tend to breathe fast. Some people, they have a psychiatric condition. Some people, they have hepatic insufficiency, anxiety, hyperventilation. We already talked about psych. And then lung disease can result in respiratory alkalosis. And remember, aspirin is a classic agent that gives you mild metabolic acidosis. Remember, mild metabolic acidosis with significant respiratory alkalosis when they have taken in moderate doses. If they have taken in high doses, it can actually cause respiratory depression. And remember, bicarbonate never falls below 12 in response to respiratory alkalosis. It's not possible. So compensation for respiratory alkalosis is by metabolic acidosis. All right. So how do you compensate? How much change in bicarbonate you expect? You multiply that PCO2 number by zero point 0.2 if it is acute, and then zero point 0.5 for the chronic. So that's how you calculate the compensation. So let's talk about metabolic acidosis. So there are two types, one with high anion gap metabolic acidosis. So the mnemonics of high anion gap metabolic acidosis is Goldmark, um, glycols, oxprolin, lactate, D-lactate, and L-lactate, and methanol, aspirin, renal failure, and ketoacidosis. Let's go over one after another. So glycol, you see glycol with so ethylene glycol and propylene glycol. Oxprolin is interesting, compound. It's a metabolic product you get with Tylenol uses. So when you check, this people from nursing home who might be on Tylenol for a long time, when you check their Tylenol level, it might be negative, but when you check oxprolin, that oxprolin might be positive. So remember that pyroglutamic acid that forms with the chronic Tylenol ingestion results in this high anion gap, and that is one of the very common cause of anion gap acidosis. L-lactate and then D-lactate, both of them can cause high anion gap. You can read over here metformin, especially in people who have creatinine clearance less than 30, can result in L-lactic acidosis. And then people with short bowel syndrome, somebody who had a bowel surgery, they might get D-lactate. And remember, when you check the normal lactate, which might be normal in these people, and methanol, aspirin, renal failure can cause. Remember, renal failure does not really give you very big anion gap. So somebody with the ESRD, you can actually use that creatinine number and divide that creatinine number by 2, and that is the maximum number of anion that renal failure can contribute. So classical example, I'll give you, let's say somebody has a creatinine of 10, so maximum 5 anion can be contributed by CKD or ESRD. So what does that mean? People with renal failure, you have to look for additional acid-base disorder that is actually contributing to metabolic acidosis. So you are supposed to look for other cause of anion gap acidosis. And then, normal anion gap you see with, this condition, which can be memorized by mnemonics, hard ups. So hyperalimentation, when somebody is actually bodybuilding, getting arginine and lysine supplementation, or getting, let's say, some kind of TPN, or acetylzolamide, which can cause RTA, or somebody actually has RTA, so that is renal tubular acidosis. And then D for diarrhea. So remember, RTA and diarrhea are the most common cause of normal anion gap acidosis. If you are actually losing bicarbonate from ureteric or pancreatic fistula, you can get normal anion gap acidosis, as you can get with glue sniffing, where people sniff thulium. So um, how do you differentiate between loss of bicarbonate from GI tract versus renal tract? Somebody with uh, anion gap, urine anion gap of less than 0, their kidney is good enough to make ammonium. So that means, the are losing bicarbonate from GI tract. Um, so how do you calculate urine anion gap? You subtract urine chloride from urinary sodium and potassium. So what are the major positive ion you are not measuring here? That is ammonium. So if somebody has, let's say good kidneys, they would have ammonium in the urine, which is not measured. So when you have ammonium, then sodium and potassium is going to be low, and it is going to be negative, because you have more chloride than sodium and potassium combined. All right, so this table is really important table. It helps you to answer many questions in the exam. So as you can see here, whenever you have very high, very high anion gap, you need to be thinking about alcohols like methanol, ethylene or propylene glycol, and sometimes we can also get with ketoacidosis and lactic acidosis. On the other hand, isopropyl alcohol and ethanol and acetone, these conditions, they won't result in anion gap. In these three conditions, anion gap is normal. That kind of helps you to distinguish between different kind of alcohol. So whenever somebody has very, very high anion gap, you're supposed to calculate osmolar gap, and then osmolar gap, if it is more than 10 to 15, you think about alcohol, what alcohol you are talking about. You're talking about methanol, ethylene glycol, or propylene glycol. Methanol you get with windshield fluid, or you see with some kind of poisoning that people get when they are drinking alcohol. You might have heard about poisoning with alcohol, so this is because of methanol. And then ethylene glycol is antifreeze. So antifreeze, typically these people, they present with flank pain because of the calcium stone, and very high anion gap and osmolar gap. So, and then salicylate, on the other hand, causes mild anion gap acidosis. It also causes respiratory alkalosis. So um, that's all about this anion. Metabolic alkalosis, primary elevation of plasma bicarbonate concentration with subsequent increase in pH. So it can be caused by combination of loss of acid or addition of alkali, we call it generation, or enhanced renal reabsorption of bicarbonate, we call it regeneration. Let's talk about it. So example with vomiting, what happens with the vomiting? So with the vomiting, basically you are going to lose hydrogen ion here, and you are going to lose water. So loss will result in alkalosis. So you start from GI tract by vomiting. So if vomit too much, your vascular compartment will go down. There will be decreased renal perfusion, which result in activation of renin-angiotensin system, and then it results in secretion of aldosterone. And the purpose of aldosterone is just absorption of sodium. And then when you absorb with aldosterone, you absorb sodium, you also lose potassium. You also lose hydrogen ion. So if you have a chloride depleted patient, like the patient who just vomited, what happens? Your patient is going to absorb bicarbonate rather than chloride. So all of these things is going to lead to maintenance of alkalosis. We're talking about the patient who just vomited hydrogen ion. We're talking about the patient who just vomited chloride, who just vomited water, who just vomited potassium. And that patient is actually peeing more hydrogen ion, is urinating more potassium, and absorbing bicarbonate. So all of these things will result in maintenance of alkalosis, and then this maintenance phase is actually dependent upon contraction of vascular volume. So replacing the vascular volume with isotonic fluid is what we do when you are treating metabolic alkalosis. So let's talk about two different kinds of metabolic alkalosis. So the first one, we call it saline responsive. So these people are dry, and when you give fluid, these people to get better. So example would be vomiting, nasogastric suctioning, or somebody who is on diuretic, or somebody who has a post hypercapnia state. Then there is a second subset of people where they are not responsive to saline resuscitation. These people, they have a urinary chloride of more than 10. So that's how you differentiate between saline responsive and saline resistant. So the cause of saline resistant, metabolic alkalosis are mineralocorticoid excess. Could be primary or secondary hyperaldosteronism. Could be from secondary because of, vascular compartment, uh, because of contraction of the vascular volume, as you see with congestive heart failure or cirrhosis or ascites. You can get also with ACTH excess, with like you see with Cushing's disease or syndrome or ectopic ACTH secretions, or also with the licorice. Our refeeding alkalosis can also result in saline-resistant metabolic alkalosis, as does severe hypokalemia. All right, let's talk a little bit about other different kind of anion gap, starting with the stool and urine. So these are low-profile tests, but gives you a lot of information. So and these are board favorite, and this principle will be tested in different level in medicine. Let's talk about stool anion gap. The formula for stool anion gap is 290 minus 2 times stool sodium and potassium. And then if the number is less than 50 is secretory, and if more than 75, that is osmotic. So in the clinically, osmotic diarrhea, they get better with fasting, and typically volume is less than 1 liter. On the other hand, secretory diarrhea, these are large volume and they persist with fasting. So these are the clinical clue that helps you to differentiate. Then urine anion gap, so there is a gap because we don't actually measure ammonium. So positively charged ion like sodium, potassium, ammonium minus chloride should be 0. So we are not going to check that in calculation. So that absence of ammonium in that calculation gives you anion gap. So, but let's say if your anion gap is less than 0, so that means your kidneys, your patient has good kidneys, which is making ammonium there. So, but if the kidney is completely messed up and is not making ammonium, then what happens? There is no more ammonium in the urine. So that means sodium and potassium is going to contribute significantly, and the combination of sodium and potassium is actually more than chloride. So that's how you determine and the clinical significance of urine anion gap. So the way I remember is negative. So negative means it's gut, coming from gut. So type 1, type 2, type 4, all this, RTA will result in an anion gap, metabolic acidosis, and when you do urine anion gap, you kind of, it helps to actually differentiate between diarrhea and RTA. This concludes the second part of the series, which is acid base. Our third part is going to be case-based approach, practical approach. If you have not watched the first part, which is ABG, I highly encourage you to watch that as well. Thank you so much. If you have any question, feel free to reach out to me with my email, sportal@mcw.edu. Thanks for watching.